Support for this podcast comes from iTube.net. iTube is ophthalmology's leading source for high quality ophthalmic surgical videos, educational series, spotlights, and more. Visit iTube.net or follow us on Instagram at iTubeNet.
You're listening to
CRST
podcast
from Bryn Mawr Communications.
Hello, everyone. This is Rob Weinstock from the Eye Institute of West Florida, and I am also one of the chief medical editors of Cataract and Refractive Surgery Today. And I'm here with my two very, very dear friends and co-chief medical editors of the publication, Dr. Kathy McCabe and Dr. William Wiley. Thank you guys for being on this podcast. We're going to be talking about high volume cataract surgery, trying to help surgeons a little bit understand some of the ins and outs and maybe some pearls to help them be successful. My practice is in Tampa Bay, and I started out kind of small mom and pop practice about 20 years ago and kind of grew into a high volume cataract and refractive practice. And it's kind of my passion in what I do. So hopefully I can be impactful. Kathy, tell us a little bit about yourself.
Yeah, so I am very happy to be here with my two dear friends, Bill and Rob, and I am your southern neighbor, Rob, just a little bit south of Tampa in Sarasota and Bradenton. And I also had a journey to being a little bit higher volume cataract surgeon, but I actually was fortunate enough to jump into a practice where actually Bill, your dad, Bob, had already established a very high volume, and he was stepping away from Indiana to spend more time in Ohio. And so I started out pretty high volume, what I thought was high volume. Of course, it got a lot higher from there. Now I think about the fact that, one of my colleagues is like between 50 and 60 a day. And, how our definition of high volume has really changed over the years as well.
Bill, how about you?
Yeah. So Bill Wiley here, medical director of Cleveland Eye Clinic and Clear Choice Laser Eye Center in Cleveland, Ohio. And I guess like Kathy, I had a mentor that was my father, and he had established, high volume early on. And I remember in residency, on a busy day, we would do 3 or 4 cataracts, and that was really busy. And then I came straight out, and my father was kind of on a faster track to retire. He retired in about 6 months after me joining him. And so I remember within the first month or two, we were doing, cataracts in the 30s or something like that on a day. And I just remember thinking, oh my gosh, this is, really, it was a lot initially. And I think there are things you can do. There's strategies and ways to approach it. But I just remember I felt like I went to 0 to 100 quickly.
And I think that's one of the nice things about this discussion is we're going to talk about some of the things that we've learned over the years that help us to keep the level of quality of care as high as possible without sacrificing that, but increasing efficiency. And I just know in the next few years that's going to be so important because the volumes are increasing and the number of providers definitely not increasing, if anything, decreasing over time. So,
yeah, there's no question that no matter how a surgeon gets to be a high volume surgeon, it took a lot of work and a lot of practice and almost like training for a marathon. It's not something you just do overnight. And you need the right team and support around you. Even when I look at our fellows that first start working, they are absolutely exhausted after a day of, an afternoon of doing 25 or 30 cataracts. And, for people that do it on a regular basis, there's a muscle memory. You learn how to manage the stress. And you know what? It's probably not for everybody. And that's okay. And I think people also have to take a look at their internal compass a little bit and what kind of person they are, because you don't want to get into a situation, as glamorous as it may sound or great as it may sound, either from a financial standpoint or just from a point of being busy and efficient. If it doesn't make you happy and you don't function well in that environment of fast-paced work like that, and it's too overwhelming, you're not going to enjoy yourself, and you're probably not. That'll rub off on the patients and the staff and everything. So I think to your point, Bill, everybody's got to find their sweet spot, and there is no perfect answer for that.
can I just set something up at the very beginning of this discussion? Because I think it's so important that the focus of this discussion is not speed. We're not talking about speed. We're talking about keeping the level of quality of care as high as possible, but being very, very efficient. And to me, that means we're not wasting time, but we're not cutting corners. So if speed is your primary goal, I think that's where we start seeing the outcomes and patient experience fall away. So it's always those two things are the most important. And then if we're efficient, we do those at a quite quicker pace.
Yeah, to your point, Kathy, there's different types of speeds. There's the speed of the surgery, and everybody operates at a different pace. But there's also the speed of the process of moving people through the process and the throughput, and your infrastructure handling that throughput. Because where things get in trouble, and I think we've all been there, is where something slips through the cracks. A patient changes their mind the day before surgery, and the message doesn't get from, say, the clinic to the surgery center because things are moving so quickly. There's so many little processes and double checks and triple checks in the system that have to be put in place. And a lot of those systems, at least for me, didn't get put into place until mistakes were made. And we said, well, how did this happen? How did this slip through the cracks? We need to create a protocol to prevent that from happening again. And we literally are still making those protocols as we grow and change because the landscape is changing. I'm sure you guys have had similar experiences to that where you've had to learn things the hard way.
I like to say that volume is dependent on complication rate, and your the human psyche and or your staff or your referral network, whatever it is, likely can only handle, let's say, one complication a month or something along those lines. And so if you have a 10% complication rate, you're pretty much going to be dictated to about about 10 cases a month, and that would be that 1%. That 10% would give you that one complication per month. But if you can decrease your complication down to, let's say, 1%, then in a given month you might be able to do 100 procedures. Or if you can decrease your complication down to a 0.5% or whatever it is, then you could do 200 procedures in that given month. And so because if you look at, it's either your referral networks, you're not going to have the referral networks if you're having higher complication rates, or interpatient referrals, word of mouth is going to go down, or just your own staff is going to put brakes and resistance on if they we can only handle so much. And so if you're delivering great outcomes time and time again, you're going to see all those things grow. You're going to see your staff gain confidence, your referral networks gain confidence, yourself gaining confidence, and that allows that volume to grow. But like you said, if you're trying to go fast, fast for fast sake, likely that's the point when you're going to have those increased complication rates, increased vitrectomy rates, or whatever it might be. And so I think focusing on quality first allows the volume to grow.
In our situation, one of the things that we recently, and I think it's just relevant because it's not like this is some time early in our careers, we like figured out the secret sauce and then that was it. Like we're constantly reevaluating, constantly innovating, constantly trying to refine our process to make sure that we have the best patient experience, best outcomes, not missing anything, not cutting corners. And, one of the things we recently made sure we did is sometimes you'll have a patient where you want to put a bandage contact lens on prior to them leaving the surgery center. Maybe they had a very dry eye or a little bit of loose epithelium or whatever it is. And just making sure that we have a way of indicating that so it's not missed if you have other colleagues who are seeing your post-operative patients, and making sure that the communication is effective and clear and is consistent and not missed. So we've just implemented a system of putting a bracelet on the patient, and it's just because we're continually innovating and trying to figure out better ways of doing things. So I think these kinds of meetings of the minds where we share our pearls help us not to have to reinvent all the wheels ourselves, but to leap forward in how we're doing things and keep the quality of care up, but as efficient as possible.
One of the things that we have to, before we even get to surgery, is to have a really efficiently well-run clinic with the right type of patients in front of you, and the right testing done and the right staff to help you make a good decision preoperatively. And is there any pearls that you guys have that keep the clinic moving at a pace that can keep up with the volume, and then having that be balanced with the surgery schedule?
One thing that was a turning point for me as far as volume was the day I realized I'm going to limit the type of patients I want to see. And it's a little counterintuitive, but I said, you know what? I'm only going to see pre-ops. Let's say cataract, or surgical pre-ops, and then also post-ops or complicated post-ops. But I was no longer going to see dry eye evals or routine glaucoma evals or routine diabetic evals, and it was a little counterintuitive. In residency, we're sort of taught just see as many patients as you can, and then chances are you'll get some cataracts that will trickle through, and that's the best way to grow your volume in residency. And I think I would still recommend residents to do that. But once you're in private practice, you start to realize your clinic can get filled up. Whatever you're willing to see, that's what will hit your clinic. And so if you're willing to see double vision evals, great. People start referring those to you, but those take a long time, and chances are you're not likely, that's going to take 4 slots of cataract pre-ops if you see one complicated neuro, ophthalmology eval or whatever it is. And so if you can focus your energy and what you like doing, and now if you love seeing the complicated neuro, evals, great. Then you're going to be a good place. You'll fill your clinic up with those. But if you'd rather be focusing on surgical, pre-ops, and higher volume surgery, I think designing your clinic to focus on what you really like doing, I think is a big step forward.
Yeah, I would totally agree with you, Bill. I mean, I do the same thing that I see preoperative patients, and I think we all have, all three of us have integrated practices where, we work closely with optometry. That allows us to have sort of that, the well patient or the more clinic based evaluation prior to diagnosing them with a surgical problem is taken care of by your colleagues. And then you're really seeing the patients who need your surgical skills. And I think that in the future, that's going to need to be more and more of the model that we follow in order to have the surgical need that's out there actually handled by the people who can do the surgery. So yeah, I think that's a critical piece of making sure that your practice is focused on allowing you to be efficient in providing surgical care.
Yeah, those are great points. Some of the things we've done in our practice that have really helped me maintain the pace and the give me longevity in what I can do so I don't burn out is, I've really worked hard to make all the staff members really bond with the patients, all the way from the front desk, like really make sure it takes the burden off of me of always being the only nice guy. Everybody needs to be nice. Everybody needs to be kind, and everybody needs to be educated. So as the patients ask questions, that the staff just doesn't say, well, you learn, the doctor's going to talk to you about that. Like our technicians, our surgery counselors, our front desk, they know what astigmatism is. They know what the premium lenses are. They can answer basic questions. They're not going to make decisions for patients, but they're going to help educate the patient. So hopefully it'll be a more efficient process when I do see the patient. Um, I like to, make sure I have an OCT and a topography on every patient so I really can just get the decision making done and I don't have to come back to it. I think you guys probably do this too, but you employ the help of a lot of talented people. It's a team approach, and we even approach each patient as a team and educate the patients that it's a team. And I know you guys get help with biometry, and at one point in time, maybe 15 years ago, that was kind of thought to be crazy if you weren't picking your IOLs. But now, if you look around at a lot of these high volume practices, many surgeons have trained people in their practices that are equally as smart and knowledgeable as we are, and we've educated them about the process, and we trust them to help us get a lot of the work done. The surgery counselors is such a critical point. I know it is for you guys as well, because they're the real linchpin of getting these people comfortable, relaxed, make them feel like they're in good hands, help them understand the surgical packages and what the options are. And those conversations are usually well longer than any of the conversations we have with the patient as surgeons. So what a critical member of that team. So those things have really helped me create an infrastructure that's sustainable, having all that help.
Yeah, the other thing I would say is just exactly what you said. It's so critical to have your scribe, for instance, know exactly the words you would use to describe some part of the exam or some of your conclusions. For instance, what does astigmatism mean and why is that important? And to have your staff be able to have that discussion maybe when you're not in the room, because they know exactly the words that you would use to describe that. It's going to be very consistent from the conversation with your scribe to you to your surgical counselor to your biometrist to whoever, that the same language, the same message is being conveyed to the patient, so it's not conflicting. So we do have, meetings every so often because we have new staff. We have, things we may have changed in how we deliver that information, just to make sure that our messaging to the patient is very consistent. And exactly like you said, Rob, I worked very closely with my biometrist for the last 15 years, where I know she knows all the red flags that I would be concerned about. She knows the things that I would prioritize in deciding what lens to pick for different options. She knows how I would speak about those options to the patient. And, we work like a seamless team. They really are extensions of me and what I would say when I'm not present. So I think that's really, really key. It's a really good point.
Bill, what about the communication between the clinic team, the lens picking, the surgical schedule, the how you design your surgical schedule, and then communicating that to the OR? Now you have your own surgery center, Kathy. You do as well. I do as well. That's needless to say a tremendous advantage when you are kind of in charge of the entire ship and you can dictate the whole process. Not everybody has that, and I would imagine it's harder to have a higher volume practice if you're at a multi-center surgery center where there's a lot of cooks in the kitchen and you really are not in much of a decision-making position. But even if you're not, what do you do, Bill, to make sure that communication is seamless, that patients are hearing the same thing and don't get confused by different messages or different sets of instructions?
Yeah, I mean that is complicated. Even though we're all under one business entity, our ASC and our clinic, they do function as sort of two independent units in a lot of ways. The ASC has its own sort of regulations and rules and hierarchy and nurses, and can be complicated to get the message from your clinic to the ASC team, properly. And a lot of it is, we do have to, you want to make sure obviously the lenses are ordered, let's say a week ahead of time or whatever time. You want to make sure that lens list is there and ready, that the ASC will look through the consignment, assure that that they've got the proper lenses. And chances are, when if it's a pretty straightforward lens, it's going to be there. But if you're picking a high diopter or low diopter, or a high torque or whatever it might be, it's critical for that information to go from one place to the other. And I think that does pose some issues. With higher volume, we're gonna, there's a chance you're gonna have two of the same lens on the same day, so you want to make sure you have the consignments ready. But it is an important part of the communication chain. I assume, right now we're not using software for that, but I assume some of the new software packages are going to help help streamline that. Yeah, I can envision a world where you've picked the lens, or the software knows, it looks at the biometry and they're like, okay, they're doing an advanced lens, and they're just going to automatically know, have a generated list itself. All the new software packages, have that. The smart suites that are being developed by pretty much all the major companies are going to help streamline that. Right now, we're not utilizing that, but I can envision a world where that type of software will make the communication easier and better.
Kathy, what do you do when obviously you're highly regarded as a skilled surgeon in handling complex cases, and you've published some amazing videos and techniques like with the belt loop and other things with Sona and IOLs. How do you manage being a high volume cataract surgeon, but also offering those particular cases and challenging services in your practice?
Yeah, I think it is a thing where you really want to think carefully about where in the schedule you're putting different cases, because for a busier day, one of the things that makes that go forward in a stress-free way, where patients aren't waiting too long, or you don't have enough patients, that they're not dilated adequately, is having a smooth flow for the ones that are very predictable. So certainly we don't put those complex cases or anybody who looks like they could potentially be a complex case, because we don't always know, right? We don't put those in the body of the day. We either put them right before lunch or we put them at the end of the day, where we have a little bit of flexibility so that I don't feel rushed and I don't feel the pressure of the patients who are in the preoperative area who think that they're going to have surgery at a certain time but are getting delayed. So the flip side of that is it's at the end of the day. So it may feel like, wow, I'm just sort of, I'm done at the end of the day. I'm a little tired. I'm not at my best. Maybe that's not when I want to put those complicated cases. And so what I have also done is have a shorter schedule on a separate day that's simply for those more complicated cases. So that day is scheduled with the cases far enough apart that I'm not rushing, and yet I don't have a very typical case after a complicated case where the timing may not be as predictable. So I think there's a couple of different ways of approaching that, but you have to be cognizant of the fact that there's just a less well defined period of time that you need to have carved out for that case. And I think the worst case scenario is to feel rushed. I want to give my 100% attention all the time that's needed to whatever the patient needs. So the more predictable the case is, the more we can put it in the flow of things. The less predictable, the more I want to have flexibility in the time.
Yeah, I mean, I've evolved to such a similar thing, and I think it's just the nature of the beast. You figure that out the hard way, and you evolve to what works for you. And it's incredible how, as you start doing more and more volume, how meticulously you have to be in crafting that surgery schedule. For efficiency and flows. We happen to do all our right eyes first and then all our left eyes, or vice versa. So that increased efficiency in the turnover of the room and how the patient's brought in, and the microscope and phaco machine set up. So we're not constantly flipping the machines back and forth, which takes extra time during setup. Um, of course, the cases that require a sewn-in IOL or something, um, something kind of heroic like that, we're gonna really carve out some extra time. But I've gone really deep in, like, when I see patients in clinic, if they have a 4NS cataract and pseudoexfoliation, I might say, like, I don't need this to be the last case, but I'll call it a near last case. I may not have any trouble with it, but I definitely don't want that as my third or fourth case. And next thing you know, I've teared the bag or lost the capsule, and now it turns into a 40-minute case, which means that if I had 20 more cases to do, all those patients are backed up. They're getting angry. Their dilation is going away. Their anesthesia is not on track, because everything is timed so perfectly when you get into this, what I would just call the flow of high volume cataract surgery, where you stay focused and you stay in the zone. And everybody stays in the zone. And I think that there's something to be said for this. It's like a basketball team or a sports team or an orchestra is
Or
another
a
great analogy,
ballet.
or a
I like to
ballet.
say it's a ballet.
Yeah, there is no one star of the ballet or the sporting event or the concert. There might be a soloist, but you've got to have everybody on point with their note and their timing for it to really go well. And it gets out of gear a little bit, and the whole performance can really be compromised. So it's amazing how much you have to craft that. And the staff, again, in the OR is equally important as it is in the clinic, in terms of everybody being there for the right reason, and leaving their personal or challenge, everybody's challenges in life. They have to be so patient centric and outcome focused, laser focused, as much as the surgeon is focusing on the eye. They're focusing on the priming of the machine, the cleanliness of the instruments, the turnover, the documentation, the double checking of the IOL power, the timeout. It's amazing how many moving parts there are to make this go in this seamless fashion quickly.
I think the other thing is to keep people with some level of flexibility, because sometimes you do get into this flow, which is very important, and the entire orchestra, the entire ballet is, right on point. But something will throw it off. You have somebody who came in late or ate something, and so they have to be delayed a little bit, especially with my particular CRNAs, they like to be very, conscious of the timing of things. but or they just didn't dilate as quickly, and you want to give them a little bit more time to dilate. And I think it is important, as much as you want the ballet to go exactly as it's scripted, to allow for some flexibility. Sometimes it's good just to have something that throws you off a little bit so that you can say, okay, how do we react to this as a team and keep our coordination and keep the patient experience at a high level, even when it's throwing us off of our original script a little bit.
Bill, what can we do as surgeons when we get to the point in the pinnacle of our skill set and efficiency where we know that we want to do X many patients in clinic and X many surgeries in the day, and we push our staff too far? And how do you maintain and engage the staff to be as motivated as you, the surgeon, to see things go as perfectly, as efficiently, and maximize everybody's time?
Yeah, that can be challenging, particularly over the past few years since COVID. I think we've all been pressured as far as keeping the best team and the best staff. We've seen turnover. We saw a lot of people just did not come back after COVID. They stayed home. And then you had, at least in our market, we had some wage inflation. So the hospital systems were at a major shortage. And so they started, stealing or hiring staff from private offices. And then we're having to hire new teams and then starting with training. And so we're short staffed, number one. And on top of that, the team maybe is not quite as efficient. And we found that put tremendous amount of pressure. And we didn't want to lose the team. Sometimes they're like, okay, we're already short staffed. Wiley, if you schedule that full schedule, we're going to lose more people. Or people are going to just not, they're going to call in sick on your days. Do you really want to push them that hard? And so that is a balance, and it's not easy. I think if you get the team all bought on to the same mission, and they can get bought into seeing like how happy patients are, how great of outcomes they're achieving. You share the reviews. If there's good reviews on Google or good reviews on feedback, you have morning huddles. Share that, and then the team realizes like, gosh, it's not just the doctor that wants to do more cases to bring home a bigger paycheck or whatever it might be. They're looking like there's a need out here. The doc's doing great work. We're trying to serve as many patients as we can. And when people buy into that mission, I think it's easier. And so building a culture of excellence and excellent outcomes, kind of what we started with early. If you have that as your driving goal, then volume will follow. And I think you'll build a team that will help support that mission. And so a lot of it's building culture. And I know, Rob, I've met many of your team members, and I know you bring a lot to the, meetings, and they see what you do outside of the OR. And I think that's important. You've been an expert at that. And I've met so many of your team members and, enjoy. I'm like, gosh, I want to work on Rob's team. I want to be part of that. So, a lot of it that is that culture. And if you can build it, I think it can be a little bit sort of magnetic and help, snowball and build that stronger team.
I think it's that mutual respect that you have for your team members too, like showing them how important and how valued they are in the whole process goes a long way. And I would say another thing is we've had some complicated cases lately where there's a lot of decision making. I always do ask for input on complex cases too from my team that's in the room, and deciding maybe we have to do something different with the IOL or whatever. But something that they really value that I think is sometimes missed is closing the loop with the ASC team and saying, that patient that we had that was complicated, here's how they were doing at 1 day post-op. Here's how they're doing a week later. Like a lot of times they never get that feedback, and they never get to understand what happened to the patient post-operatively. And I think that really helps to ground them in how important it is, all the things they're doing, especially when there's even more stress or a little bit more complicated case going on.
Yeah. And back to a conversation we were having earlier about the patient perception and the patient experience, and how equally important that experience is of that they have throughout the entire process, almost as important as the visual outcome, that they have this amazing experience and process is so important. And, I've learned so much from some of my mentors, like, Vance Thompson and Eric Donenfeld, Paul Walton. I mean, I've seen this, the little things. And Vance said something the other day on some chat about, slow motion, um, slow motion communication. And I didn't really understand what he meant. He elaborated, and it makes total sense. It's like you don't have a lot of time with the patient. You've got a few minutes preoperatively, you've got a few minutes in the operating room. But during those 3 to 5 minutes in the operating room, you've got to turn that 5 minutes and stretch it into 30 minutes in the patient's mind. You've got to look them in the eye the whole time. You've got to shake their hand. You've got to introduce yourself. You have to show kindness. You have to show caring. You have to build trust. You have to be engaged 100%, no matter what else is in your mind. Same thing in the OR. You might be doing 20 or 30 cases in 4 hours or 5 hours, and you want to go and move because the patient's ready. You pull that drape off gently. You put your hand on their shoulder. You say, "Hi, this is Dr. Wiley or Dr. McCabe. You did great. Everything went perfect," because these patients are lightly sedated. They hear you. They remember those little touch points. And that really resonated with me. And, I've seen so many of the masters who are just, they're like magicians doing all they do in life. They do that amazing ability to bond with the patient at those critical moments. You can't forget to do that.
I think you mentioned some really key parts of that. You touch the patient, you look them in the eye. It's such a simple thing. And when you're in the exam room, you sit down to answer their questions. You don't stand up and get ready to leave the room while you're answering questions. And it's, even though it'll take you the same amount of time to answer the question, it's a very different perception if you're sitting versus on your way out of the room and with your hand on the doorknob kind of thing. So I think those are really key points that you pointed out.
Yeah, I think a lot of people probably from afar look at high volume surgeons and are like, oh, that's, they're just being fed by optometry and they don't talk to their patients. There's no way they, this is just, for whatever reason, they have a perception. But the real high volume surgeons, they didn't get that way by accident. They got that way by delivering top level experience for their patient and top level surgical outcomes. And that doesn't happen by accident. And then it evolves. And that's what I've kind of come to realize is there's no, like, you start off small and super mom and pop and friendly and a real, or very patient oriented and lots of time, and then all of a sudden eventually your goal is just to be in the operating room. I mean, there may be some cases like that, but in the real world, I don't think that's the reality of our colleagues that are high volume surgeons. I think they've just taken all the things they've learned and they've just learned how to do it better and more efficiently and more effectively. Bill, you've probably seen that over your career as it's grown.
Yeah, so true. And I think creating the experience, like you said, you said, Rob, you touched on so many things. I want to reiterate it, but that slow motion, even in the OR, even if it's not you, you want to make sure your team. It makes me anxious if I see them running around, and if patients pick up on that. It's like, listen, I know we're trying to be efficient, but the perception is everybody has to be going kind of normal speed, not rushing, kind of chill. Even though you may be doing higher volume, everybody has to go at a normal pace to give the perception that things are in control. Things are, you're creating that amazing experience. One of the things Paul Walton taught me, he asked every patient, he said, has everybody answered all your questions? And what that sets up is, chances are the patient's going to say, you know what, gosh, the whole team, there's 5 or 6 people were there to answer my questions along the way. And by the time they get to Paul Walton, at that point, they're like, you know what? Yeah, everyone has answered all my questions. And like you said, Rob, that one question allows Paul to kind of lock eyes with a patient, make sure everything's been answered and move on. And maybe his interaction is only 5 or 10 minutes, 5 or 10 seconds, let's say, in that one interaction. But the patient perceives that Dr. Walton was definitely motivated to make sure that the patient was going to have the best possible experience, and all those questions were answered. And if the patient is like, you know what, actually, I've got these 6 questions. Okay, great. Then you get another team member. You get one of your colleagues or your doctor, or it could be Dr. Walton himself or whoever it might be, can circle back and make sure all those questions are answered. You don't want to proceed unless that's happened. But it's something simple as that can really set the tone to giving that best possible experience for that patient.
That's very good advice. Well, we're kind of running towards the end here of our time, guys. Is there as a last question, anything you would advise a surgeon as they grow and they reach for the stars and trying to craft their perfect practice to avoid maybe burnout or overwhelming themselves? How to balance that, or is that just too personal of a journey?
I think there's some things that you can do that keep you appreciative of being involved in such an amazing profession, and really what we do is so fulfilling. Really, we get to restore sight, and keeping your eye on that, and the fact that it's not you alone, it's a team, and always celebrating the fact that you're a part of a team. I think that that's important. And I think it helps me to stay grounded and realize, sometimes no matter what you do, there's a complication or there's a stressful moment, but sitting back, taking a breath, approaching it with kindness and appreciation for everybody around you and the team that you're working with in a calm way. I think that keeps me from feeling overwhelmed. The fact that it's not just me, it's a whole team, and I'm appreciative of them. If a patient says, I'm so glad you were my doctor, thanks for doing a great job, I always say, nope, it wasn't me, it was a team. You had the A team. And I think if we always keep that in mind, it just grounds us and keeps us a little bit, maybe a little humbler, but also a little bit more appreciative.
I love that. I love that. Bill, what tools do you use to keep you from running out of steam?
Gosh. Yeah, I think if for good or for bad, I think we've sort of touched on this a little bit throughout the way. It's sort of, we're always trying to be better at what we do. It seems like every few months we're adding new technology or new software or new approach or new technique, and we're always trying to improve. You're sort of never satisfied. And I think the team buys into that. They see that we're not just a static, organization, that we are trying to improve the quality of care consistently and constantly. And there's always some kind of new tech that will let us do our job better. And I think that keeps things fresh. It's always a new environment. There's always something new to learn. And I think that's helped sort of prevent that kind of burnout by just doing the same old thing every day. Let's say, by adding new technologies or approaches. I think it does keep things fresh for not only yourself, but also the rest of your team.
Amazing. And the only thing I think I would add for myself is I think helping not just the patients, but other surgeons be successful through mentorship. And I know you guys are incredible mentors in the space as well. Is a very fulfilling and satisfying thing that does keep me grounded as well and keeps me looking at the eye in the future and humbles me. And I can't thank you guys enough for sharing this amazing wisdom and pearls. This is very philosophical, but also yet some very direct and purposeful messages and points that hopefully will help surgeons. And always great working with you guys. And to the listeners out there, thanks for joining in. We hope it was super helpful for you. And of course, Bill and Kathy, and I know I can speak for them, are always available to help anybody through any challenges that they may face, because I know I've had many people that I've reached out to over the years to help me. So until next time, we will see you soon.
For more shows like the one you just listened to, check out the podcast channel on itube.net.